Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the PALM series, which is practical aspect of lab medicine. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join to access all lecture related information. We also have a Google Drive where the PDF of all the lectures are uploaded and the master integration key by which you can navigate between the PDF and the YouTubes. These are the disclaimers, and here we would like to specify and also emphasize that we do not sponsor any company, group or organization. Reference to any particular brand is purely at the discretion of the presenter, solely done for the understanding and explaining the subject. We do not subscribe to any brand. And we are with phase 3, which is the recorded pathology lectures. And today we have PALM-03, which is tumor markers in clinical practice, and we are streaming from Apollo Diagnostics Zonal office, Kolkata. And to talk on today's topic, which is tumor markers in clinical practice, we have Dr. ABHIK BANERJEE, who is an MBBS from Kolkata University, MD Pathology from MUHS. He's also an MBA in Healthcare Management. He's a Zonal Technical Chief, East Zone Apollo Diagnostics, Regional Reference Laboratory, Kolkata. And as you can see, he has got more than 10 years of experience as consultant pathologist. He's also been the internal examiner for DMLT curriculum approved by the state medical faculty. His research areas are lab medicine, pathology, routine and specialized chemistry, and various aspects of health management and laboratory operation. He's got many articles in national and international journals. He was also awarded the Leadership Award in 2019 in the Achievers category by the Indian Express Group. With this, I would request Dr. ABHIK BANERJEE to start his talk on tumor markers in clinical practice. Over to you, Dr. BANERJEE. Thank you.
Good afternoon. Today's session is tumor markers in clinical practice. So, what are the roles in cancer management? Roles of tumor markers in cancer management. We have to understand why, what, when, which and how. That means why we will use tumor markers for cancer management, what tumor marker, which tumor marker, what tumor marker we will use, when, at what stage. It may be diagnostic, it may be prognostic, or it may be at a treatment phase, therapeutic phase. When we will use, which particular tumor marker we use, and how we will use. So all these we should know to understand the role of tumor markers in cancer management. So first, why? So why we will use, right? So if a patient is being suspected of having any cancer or malignancy, what are the expectations or interest of clinicians in management of that patient? So first they want to know whether it's a benign or malignant disease. First, it's a suspicion is there, right? That it may be a tumor, malignancy. So first they want to know the confirmation whether it's really a malignant disease or not. Then early detection in order to maximize chances of survival. We all know that in a case of malignancy, the earlier you detect the case, the chances of survival is more. To monitor response to ongoing therapy. So whether the tumor marker or any diagnostic test or any test which you are using, whether that is useful to monitor the response to the therapeutic process, and at what frequency we will measure the tumor marker during apparent clinical remission. That means we all know that malignancy or cancers is known for its relapse. So following a successful chemotherapy or radiotherapy or a surgical process, we all know that tumor markers are used to understand that whether the cancer is coming back. That means whether the cancer is there is a chance of relapse. So at which frequency we will measure or will use the tumor marker to understand that there is a relapse, because if there is relapse, immediately we will start therapeutic intervention. So it is important that these features should be present. These are the expectations of clinicians from a tumor marker during management of a patient suspected or confirmed case of malignancy or cancer. So now, after the clinician's interest, we would like to understand what are the patient's interest. Patient's interest, he or she doesn't know much about the technical things. What is his or her expectation? Can I be cured following treatment, or there is a chance of reappearance? So can I be completely cured? Can I be cured following treatment, or there is chance of reappearance? Provided the answer, what is the answer? That provided there is absence of micrometastasis or no microscopic residual disease at the end of treatment. So if there is no microscopic residual disease at the end of treatment, possibly it's a cure. Sometimes it is difficult to answer because morphological investigations or radiological investigations are unable to detect that kind of relapse. Okay, you are doing a biopsy, histopathological examination, even this or the CT scan or MRI something, it is very difficult to understand whether the cancer is coming back, whether there is a chance of relapse, because histology, histopathology or radiological investigation, mostly they will tell you about the current scenario, whether it is present or not at this moment, but it is very difficult to predict that whether it will come back in future. So we need a very highly sensitive molecular marker, right? So that it can immediately, it can detect, it can predict that yes, this cancer is going to come back. So that kind of highly sensitive markers are required, where they can give you an idea that whether the tumor will relapse in near future. Like for example, we are using beta HCG in follow-up of choriocarcinoma, right? So beta HCGs are being used for continuous monitoring after a successful chemotherapy in a case of choriocarcinoma. So now, what are tumor markers? So tumor markers are the biochemical substances or metabolic products produced by tumor cells or related to presence of tumor, that is body's response to tumor, found in body fluids or tissue or tumor surface of patients with cancer. Tumor markers are a wide variety of molecules, including DNA mutation. This can be mRNA, this can be transcription factors, cell surface receptors or secreted proteins, enzymes or hormones. They are found in blood, urine or body tissues that can be elevated higher than normal amount by the presence of one or more types of cancer. So please understand this, that the presence of a tumor marker, right, it may be in the blood, in the urine or in a tissue. So it's a live tumor cell, they are secreting markers, or there may be apoptotic or necrotic tumor cells where there may be a passive secretion of these markers. So if this is a primary tumor, so these are diagnostic biomarkers, like they may be present in the gastric juice, they may be present in the stool or feces. There may be presence also in the serum or plasma. So either they are being actively secreted by the tumor cell, live tumor cell, or they may be passively secreted following lysis of a tumor cell, of a apoptotic or necrotic tumor cell. Following lysis, they come out, maybe in the gastric juice, maybe in the body fluids, maybe in the serum, plasma, urine, etc. So what is an ideal tumor marker? We all know that nothing is ideal in this world, but what should be our ideal tumor marker? A tumor marker should be highly specific. That means it should be detectable only in one tumor type, right? If there is a tumor marker, like example, if it is increased, we can pinpoint that yes, it's a lung cancer, or it may be a colon cancer, or it may be a gastric cancer. So ideally it should be, because if it is not specific, like if a tumor marker is elevated in multiple different types of cancers, how you will get to know without any additional marker or additional test that whether he is suffering from liver cancer, or it's a colon cancer, or it's a lung cancer. So ideally it should be highly specific for a single kind of malignancy. It will increase in that particular cancer only. It should be highly sensitive, as I told. During relapse it is very much important, or during first time diagnosis. Even if there is slightest numbers, very few numbers of cancer cells, even it is a very initial stage, that time also the tumor marker should be elevated, should be detected, right? And it should not be detected when there is benign state. When there is no cancer, it will not increase, but whenever there is even a single evidence of cancer, it will immediately increase. Third is long lead time. So that means there should be sufficient time for alteration of natural course of disease. That means it should be detectable in occult disease also. When the cancer is hidden, but it is going to appear soon, morphologically when it will be evidence, clinically, clinically, phenotypically when it will be detected. Before that, even if it is hidden, but it is there is no symptoms of malignancy, but still it is present. At that time also the tumor marker should be able to catch it. At that time also tumor marker should increase in the body fluid or plasma or serum, whatever as applicable. Levels correlate with tumor burden. That means the prognostic and predictive utility of a tumor marker. This is very important. Like if we could just imagine, if we could say from a CA 125 that if it is more than 2000, 1000, then this is very, severe disease. When it is maybe 500, it is moderate, right? This kind of when it can correlate the level in serum, blood or body fluids, when it can correlate with the tumor burden, overall load of the tumor, it is very good then. If this characteristic is present, if that characteristic is available with the tumor marker, obviously it should be accessible, affordable, and very simple. It's it should be affordable to mass population. You have invented, you have discovered, or you have a tumor marker in your laboratory, in your basket, but it is very costly, so most of the people are not able to book the test. Then what is the purpose? Because most of the people will not be able to gain the benefit from this tumor marker, right? So it should be affordable, accessible, and easily available. And next, easily obtainable specimen. Best is, see, like a blood specimen, urine specimen. So this kind of specimen is very easily accessible, so you can easily collect the specimen. So these are the ideal characteristics of the tumor marker. So now these are the classifications. In different ways you can classify, but this is just an example. Like as I told, tumor markers may be of different molecules. It may be a RNA, it may be a DNA, it may be a protein, etc. Anything, enzyme, hormone. So see, oncofetal antigen. So like for example, alpha fetoprotein CEA, where it is increased, we all know. AP is increased in liver cancer, but it also may increase in germ cell tumors of York sac origin, non-7mm testicular cancer. CEA, it increases in colon, lung, GIT. So actually see, as I told, nothing is ideal. So ideally tumor marker should be specific, but are they very specific? APCA? No. Because alpha fetoprotein may increase not only in liver cancer, but may also increase in goadal tumors. Like for CEA, usually it is used for colon cancer, but it may also increase in lung and GIT, gastrointestinal tract. So these are not specific actually, but yes, like CA125, it's a glycoprotein. It is mostly used for ovarian carcinoma, but we all know that CA125 may also increase in some benign condition also, false positive. Right? Even in pregnant, in menstruation, during menstruation, it may increase in fallopian tube, vaginal cancer, endometriosis. In different conditions, CA125 may be increased. Maybe in ovarian cancer, it will increase like anything. It is very high. The values will not be so high in such benign condition as I told earlier. But yes, basically they are used for CA125. CA15.3, it is more or less specific, breast cancer. CA19.9, more or less specific for pancreas, but it may also increase in stomach cancer. So these are glycoproteins. So these are some of the examples. Like you see, enzymes, HPV, human papillomavirus, then neuron-specific knowledge, it is increased in neuroblastoma. Okay, there are some proteins also like immunoglobulins, multiple myeloma, beta-2 microglobulin is a prognostic indicator for multiple myeloma. So enzyme, there are some LDH which increases in seminoma. So these are the different applications. So now we will come to a very important slide. What are the utilities of tumor markers? So first is, actually if you say there are different utilities, screening, diagnosis, staging, but the most, if you are asked what is the most important utility of tumor marker, it is prognostic. Please remember that's the utility of screening and diagnosis for tumor markers. As a general, it's a general statement, generalized statement. They are basically not for screening or diagnosis. Basically they are for prognostic assessment, right? But there are some tumor markers which can also be used for screening or diagnosis. Like for example, PSA may be used for screening along with digital rectal examination. Maybe alpha fetoprotein in like African countries where this hepatocellular carcinoma is very, very endemic, where you can use AP along with ultrasonography for screening purpose of hepatocellular carcinoma. But unless it is an endemic zone, like as I told, African countries, you should not ideally use tumor markers for screening purpose. So you cannot do health checkup camp for alpha fetoprotein just using that as a screening tool for hepatocellular carcinoma in mass population, right? So that is not recommended actually, but yes, you can do for some of the tumor markers like PSA and AP. Diagnosis, BJP is one of the strongest indicator of multiple myeloma. So Ben-Jones protein, that is also a tumor marker that can be used as a diagnostic parameter. But still you imagine one thing, in a case of suspected multiple myeloma, what are the tests you do? You do a CBC, complete blood count, where you can see the rural formation. You can also do protein electrophoresis, serum protein electrophoresis, or you can do a immunofixation electrophoresis. You can do a bone marrow examination. Many things are there. So, but BJP is a very simple test where you can do it from urine. It's a very easily accessible thing, easily approachable tissue, approachable specimen, urine. So, if BJP is present, it is the strongest indicator of multiple myeloma. You can more or less say, yes, it's a diagnostic parameter. But still, will you be able, only due to presence of BJP, will you be able to stamp a patient for multiple myeloma? No, you have to do ancillary test, as I told. Multiple myeloma, bone marrow examination, you will have to do electrophoresis study, etc., etc. But say they can support in diagnosis, definitely. Similarly, calcitonin is diagnostic of medullary thyroid carcinoma. So you have to remember these kind of examples. So in general, they should not be used for screening and diagnostic modality. they can assist in diagnosis. So what I tell always, that tumor markers, they may be used as an adjunct, accessory tool to diagnose along with other investigation. But there are some tumor markers which can be used for diagnostic use, like diagnostic utility, like BJP, calcitonin, etc. Calcitonin for medullary thyroid carcinoma. Serum AFP, if it is more than 500, it usually signifies that the presence of cirrhosis. In presence of cirrhosis, so you have to do a USG also. In presence of cirrhosis, it is diagnosed by hepatocellular carcinoma, right? So these are some of the staging. As we know, in AJCC, TNM staging for testicular cancer, we will show in next slide. It is useful. We can use tumor markers for TNM staging for testicular cancer. Prognosis, it's a very, most of the tumor markers are basically used for prognosis, like beta-2M, beta-2 microglobulin multiple myeloma, hard-to-new, Ki67 in breast cancer. Okay, so ERPR positive breast cancer, how you are assessing the prognosis? If it is ERPR positive, the prognosis is usually good. If it is a hard-to-new positive, prognosis is usually bad. Monitor treatment, CEA is the marker of carcinoma antigen, is the marker of choice for monitoring metastatic colorectal cancer during systemic therapy. Okay, they routinely monitor, measure the level of CEA just to understand how the therapy is working. To predict recurrence, it is utmost important to predict recurrence so that relapse can be picked up as soon as possible and appropriate measure may be taken, like beta-hCG in choriocarcinoma, CA125 in ovarian cancer. 3 months before radiological evidence they appear. You can compare, as I told in previous slides, the CT scan radiological, they will be able to detect when it is already evidence, the cancer has already appeared. But CA125, they can even detect the possibility of relapse 3 months before radiological evidence. So that is the beauty, that is the importance of tumor markers, right? So as I told, staging cancer, AFP, alpha fetoprotein, beta hCG, LDH, in 3 combination, they can be used as AJCC TNM staging for testicular cancer, right? When it is not elevated, all 3 are not elevated, it is S0. It will be like S2 or S3 when all are elevated like this thing. So this is the protocol. Some common tumor markers, I have given some example. You can remember alpha fetoprotein for hepatocellular carcinoma, beta-2 microglobulin for prognosis of multiple myeloma, BTA present in bladder tumor antigen present in urine of many patients with urinary cancer, CA15C like breast cancer, CA125 standard tumor marker for epithelial ovarian cancer, CA19-9 pancreatic carcinoma, calcitonin medullary thyroid carcinoma, CA for colorectal. Chromograin A, neuroendocrine tumors, serum HER2-neu breast cancer, neuron-specific NOH for lung cancer, neuroendocrine tumors, example carcinoma. So there are some examples, like in CA19-9 may be elevated in rheumatic disease. Some drugs are there, anti-androgen therapy, which may falsely elevate PSA. Do not, it's a very important point, do not do a PSA immediately after digital rectal examination or transurethral manipulation or any kind of prosthetic massage. Like if you do, there will be a false PSA elevation, so it is very important. Please remember, cigarette smoking may increase the CEA elevation. So in most of the good laboratories report, you will see that CEA has a different reference ranges, one for non-smoker, one for smokers. Because in smoker it is automatically some bits of elevation may be seen. So please interpret the reports with caution. So what are the recent advancements? To overcome these shortcomings of many of the traditional markers, there is need of a newer markers which will be more specific. There should be harmonization in testing. The platforms, reagent kits, those should be all standardized. Okay, there should be some genetic markers, like they are because this is an era of precision medicine, targeted therapy. So if those tumor markers are available from DNA, okay, those will be very good. So some genetic immunohistochemical techniques, p53 overexpression, telomerase activity, these are now coming very fast. So cell-free DNA, as you know, in next detected by next generation sequencing. So in multiple myeloma, hepatocellular carcinoma, those kind of tumor markers are coming very soon. So also potential biomarker for bone marrow cancer, multiple myeloma, FAIM, fast apoptosis inhibitory molecule. These are some upcoming research. So these are the evolution of tumor markers. See, we started with Benjon's protein, that is the first tumor marker in 1846, and then slowly we have come up. So now in 2000, multiple investigations, like it's the era of genomics, proteomics. We are using microarray, mass spectrometry, then multiparametric analysis, neural networks. So we have come up a long way in tumor markers. So there are many tumor markers now available in the market and in the. So now which choose the right one, choose rationally. So you cannot use like tumor markers like in a bundle, in a package. See, some labs they should not do this, that tumor markers they are including in the package as a screening. It should not be like you. So you have to understand, you should have a very good base knowledge that which tumor marker is increasing which particular cancer, whether they have any false positive, chance of false positive, whether they are enough specific or not, whether they may increase in any other condition. All you have to know. So you have to use the tumor marker rationally. Like in a prostate cancer, both prostatic acid phosphatase and PSA increase. But which one you will use? Definitely PSA. Now prostatic acid phosphatase is an almost abandoned test because PAP is less sensitive. The idea of the tumor markers, using tumor marker, is when it is the even occult malignancy, as I told. It's it has started, relapse or something, initial stage, very initial stage. So stage A prostate carcinoma, PAP will not be positive, acid phosphatase will not be positive. But in 52% cases, PSA will be positive. So it's a very, very sensitive. So whenever the prostate carcinoma has reached stage D, it's a very advanced stage, then there is no point to diagnose, right? You have to, for cancer, you have to detect early. That is the key to successful treatment, therapy, successful patient survival. So you have to catch the disease early. So that is, we have to understand which one of these markers will be detected at stage A or stage B. So you can see that acid phosphatase is even positive in stage B. When it has stage B, even that time only, acid phosphatase only in 8% cases it is increased, but PSA is increased in 78% cases. So obviously it's very much sensitive. So that's why you will use PSA, not acid phosphatase. So probability of cancer, this is also very important. When it is PSA is in this level, see, we say less than 4 is the reference range. Why? Because if it is 4 to 10, there is a chance of good possibility, 1/4 chance, 25% chance of cancer. But if it is more than 10, then there is that 50% possibility that you are having cancer. But the better indicator for this probability is not only PSA, rather it's a percentage free PSA. What is percentage PSA? You have to do the free PSA and total PSA from the same instrument, same platform, and accordingly you have to do a percentage. So if percentage free PSA is less than 25%, then there is a chance of cancer. If it is more than 25%, then the chance of cancer is less. So probability of cancer is better detected by percentage free PSA rather than total PSA. So you can see, if percentage free PSA is 20 to 25%, so there is 16% probability of cancer. So when we actually use this free PSA, percentage free PSA, when the total PSA is in the gray zone, that means in between 4 to 25. That is very important, because you can see less than 4 is normal and 4 to 25, okay, total PSA, that means there is a possibility, because more than 10 there is 50% chance of cancer. So at that time, whether it is a cancer or it's a benign condition, at that time at gray level you have to use the percentage free PSA. But please remember that if you do only free PSA, many clinicians cite only free PSA, that is, there is no diagnostic significance. You have to do percentage free PSA or total PSA. To understand the main aim of doing a percentage free PSA, to avoid unnecessary biopsy, especially when there is in the gray zone, that means in between 4 to 10 or in between 4 to 25. Why? Because then you are not sure whether it's a cancer or it's a BHP. Okay, then you have to do a prostatic biopsy, but all patients cannot undergo prostatic biopsy, like pregnant patient, very senile, fragile patient, very aged patients. So you can do a percentage free PSA after giving a choice to customer that, see, prostatic biopsy is the gold standard, but as you are trying to avoid biopsy, painful procedure, you can do this percentage free PSA. If the percentage free PSA is in this range, if it is 0 to 10%, okay, then there is 56% chance of cancer. But if it is more than 25%, there is hardly any chance of any cancer. Most probably it's a benign condition. But if it is less than 25, then 20 to 25 is 60% chance. And jitna, how less it is, then it is more chance of cancer. Please remember that thing. If it is more, then chance of benign disease is benign, that is BPH is more. But if it is less, then there is more probability of cancer. Lower the value, lower the percentage, more the probability of cancer. If it is percentage PPSA 10%, 12%, then there is 56% chance of cancer. So this is the beauty of percentage PPSA. But don't prescribe only free PSA. Always do free percentage PPSA. Total PSA, then if you have it is in the gray zone, you go for a percentage PPSA. Next, tumor marker. We all know that for CEA it is basically used for colorectal cancer, but in gastric carcinoma also there is 59% chance when CEA will be increased. So recurrence, post-operative recurrence for colorectal carcinoma is 90%, for gastric carcinoma is 59%. But if you are using CA19-9, for gastric carcinoma post-operative, to understand the recurrence sensitivity, CA19-9 will give you 79% cases, it will give you an indication that there may be a recurrence. So you do not have any single tumor marker for gastric carcinoma. Better you have to use in combination CA plus CA19-9 for evaluation of the prognosis, for assessment of the treatment. So you have to use. But if you are trying to judge or trying to monitor the progress of only colorectal carcinoma, this CA is a much better tumor marker, and you can use all alone because it has 90% sensitivity. You will not use CA19-9 for colorectal carcinoma. You have to use for pancreatic carcinoma. For pancreatic carcinoma, CA19 has a 100% sensitivity. For pancreatic carcinoma, CA has only 31% sensitivity. For pancreatic carcinoma, so which parameter, which tumor marker will use? CA19-9. For colorectal, you will use CEA. Only one tumor marker, enough. But for gastric carcinoma, both have moderate grade of sensitivity. So please use in combination. Understood? This is a very important slide. Okay, so I am all giving some live examples, practical examples. Okay, so you can use in your day-to-day practice in laboratory. So if your clinician is asking you that which tumor marker I will use because it's a suspected case of gastric carcinoma, and you are trying to assess the prognosis, so please advise that, sir, you have to use CA19-9 CA in combination. But if it's a colorectal, do not unnecessarily burden the patient because they are already distressed. Huge amount of money is being they have to expense. So only use CEA for colorectal, only use CA19-9 for pancreatic. Okay. So effect of cutoff point. So this is very important. So reference in your cutoff, you have to use standard literature. So why you all know that CA19-9, the cutoff is standard cutoff is 37. Less than 37 normal, more than 37 is positive. Why? Because if you use this cutoff, you will be able to detect cancer in 81% cases and with 90% specificity. But if you use this kind of cutoff, 100, 300, 1000, you will gradually lose the sensitivity. Your specificity will increase. Why? Because if you are using cutoff 100, then obviously most of the pancreatic cancer will be detected, specificity, but the sensitivity will decrease. That means the early cases of pancreatic cancer will miss. So you have to use your cutoff. How these cutoffs are developed, you may doubt now why it is 37, because after thorough investigation, thousands and thousands of patients they have tested, and then they have come to know that to achieve both sensitivity and specificity important. It is not only important that you will detect all cases of pancreatic cancer, but at the same time you will detect the pancreatic cancer at very early stages. So then you have to use a cutoff which is enough sensitive and specific also. So maybe you will, if you use 100, 300, below 100, if you detect that, if you in your reference 100, below 100 it is CA19-9, that means all are normal, there is no pancreatic cancer. It is wrong, because then 68% cases you will be able to detect. Rest of the 32% you are missing. Why? Because they are in very early stage of pancreatic cancer. You will get specificity, it will increase, but you will lose sensitivity at the at the cost of it. So you will try to get a maximum sensitivity and specificity. So that's why the cutoff is 37. It's a very important slide. So these are the update of ASCO recommendations regarding CA19-9. So CA19-9 cannot be used as a sole parameter for diagnosis. So you always need an imaging, a spiral CT. However, it can be measured every 1 to 3 months during active treatment, just to understand how the treatment is going well. And a rise in serial CA1999 levels may indicate disease progression, and confirmation of progression should be established with additional testings, right? So CEA, it cannot be used as a screening test for colorectal cancer. Please remember, screening test you cannot use in a mass population. That's today CEA, there will be a health camp just to understand, because CEA may be increased. In our country there is many smokers, so that may be a borderline elevation, but that does not mean cancer. So unnecessarily do not do this kind of test. In a known case of cancer, colorectal carcinoma, it can be ordered for monitoring the prognosis, and also it can be ordered preoperatively in patients, so that it will help in staging and surgical treatment planning. How much is the tumor load, it will be able to. So post-operative serum, see at what frequency will measure, that is clear cut, there is guidelines. So every 3 months they are saying post-operative. You cannot do every 1 month. It is a burden for the patient and it will not give you any additional value. So please follow the guidelines, right? So rising trend will predict recurrent disease within 3 to 4 months, even if CT scan is negative. That is the beauty. So tumor markers, you will be able to get a response even much before than the radiological investigations. They will tell you there is a possibility of recurrence. You can counsel the patient, see now it is rising trend, you are doing every 3 months and there is a rising trend, so possibly it may come back within 3 to 4 months. CEA should be measured at the start of treatment for metastatic disease and every 1 to 3 months during active treatment. So these are guidelines. So one case study, so how you will use, like see, it's a 9-month history of amenorrhea, patient 30-year female, beta HCG was 3800. X-ray studies reveal a lesion in the left lung and a CT scan demonstrates small lesion in the frontal and left parietal lobe of the brain. Biopsy confirmed the presence of choriocarcinoma. Ultimately confirmatory is pathological examination. The patient received radiation and chemotherapy treatment. Serum beta HCG value returned to normal. 3 months later, patient came for a follow-up. We all know that choriocarcinoma is known for recurrence. It melts like snows in a case of radiotherapy, but at the same time, it is known for recurrence. And it's a very bad cancer, right? So you have to repeatedly come up for a follow-up. So CT scan and everything, USG, everything is negative. So now as you told, the best it is here for prognostic assessment, for monitoring purpose, the best is tumor marker. So which tumor marker? You will have to order a HCG. So what is the problem? The junior resident, he does not know, he studied only, took sample and sent it for HCG studies, total HCG. The result was negative. Senior consultant sent a separate serum specimen to another laboratory with a specific request for beta HCG. So what is the tumor marker? Beta HCG, not total HCG. A modest increase in serum beta HCG signaled a positive possible recurrence of the tumor. So the patient was counseled that there is a possibility of recurrence. 5 months later, X-ray studies revealed a tumor. So much before beta HCG could tell that there is a chance of relapse before the radiological evidence. But why you have to select beta HCG? Because the whole intact molecule of HCG, total HCG, it is less sensitive. It can be used for pregnancy, but it is less sensitive as a tumor marker, less specific also than beta HCG assay, since the alpha subunit is identical for luteinizing hormone, TSH hormone, FSH hormone, human HCG, total HCG. So those are actually not tumor marker. Total HCG you can use for diagnosing pregnancy, but for tumor marker you have to use beta HCG, right? Total HCG may not increase because that is it is not specific for tumor. So biochemical evidence here, a tumor marker can give you the answer of relapse even 5 to 6 months before the clinical manifestation radiological evidence. So what are the take-home message? Tumor markers, a convenient and cost-effective diagnostic tool, have revolutionized diagnosis and management of various malignancies. Recommend a panel of markers whenever available. Never rely on a single test. See, for sometimes like colorectal carcinoma, you can rely on, you can bank on CA. For a pancreatic carcinoma, you can bank on CA. But as I told, for gastric carcinoma, you have to rely on both CEA and CA19-9. And don't only use tumor marker as a sole diagnostic criteria. Tumor markers are mostly for additional, or it helps in diagnosis as an adjunct. You have to use it along with other investigation. And number 3, if you are using for prognosis, you have to serially monitor. A single value is not sufficient. combining several tumor markers, serial measurement, incorporation of novel tumor markers improve the diagnostic performance. In serial testing, use the same lab with same assay kit. Recent advances in technology provide additional malignant tumor markers in the immediate future. Overall, always use your clinical judgment. Please do not blindly rely on a single tumor marker result. It is the greatest, it is the maximum. There's a most of the people does a mistake with, as I told, like a CA125, it is raised, people are thinking I am having ovarian cancer. No, a slightest increase may be in a physiological condition like menstruation, pregnancy, or it may be a benign condition like endometriosis. So always use your clinical judgment. You have to take help of USG, histopathology, and everything ultimately to reach a final conclusion or final diagnosis. Thank you.